Right, good morning everybody. It's 9:31, so I think we'll kick off. So hello, my name is Michael Watson. I'm a member of the Mental Health Improvement System support team. I've worked for the team for 7 years now, since its inception. And prior to that, I worked for the intensive support team for physical health for 18 weeks and cancer. And prior to that, I'm an experienced operational manager in acute care. But I've been working in mental health improvement for the last 6-7 years, as I say. So welcome to our webinar this morning on understanding and eliminating backlogs. As you can see there, all of the slides and all the other gump from today is available on our Futures site. We would encourage you to engage with that. All of the resources that we're signposting, plus all the materials from our other webinars are available on the Futures site. And the details of where you can get that are on the slides. And when you get the slides circulated to you, so I repeat before people start asking questions, the slides will be shared after the webinar. When you get the slides, you'll also get the link to our Futures site if you're not already a member. Next slide, please. So, as with previous webinars, we'll be using the Menti system because it seemed like quite a popular choice last time. So for those of you that have not used the Menti system before, this is a website that you can join on your computer, on your smartphone, on your tablet or iPad or whatever you fancy in order to interact with us during the course of the webinar. As you can see on the screen, go to www.menti.com and use the code 72726361, or you can use your smartphone or tablet if it's got a camera to scan the QR code on the right-hand side of the screen there, which should direct you directly to the right Menti site, which will give you a welcome page. And in the course of the presentation, there'll be a number of questions and opportunities to interact with the team and to make your thoughts heard. So I'll give you everyone sort of 10-15 seconds just to get yourselves online there. We encourage as many as possible of you to join that. Carry on with the presentation. Okay, so welcome, as we say here. So today we are introducing our resources for understanding and eliminating backlogs in community mental health services. As I said, we want this to be as interactive as possible, and listening to your feedback from our feedback questionnaire from previous sessions. We've got a mixture of speakers from members of the team. We've got some interactive surveys using the aforementioned Menti business. We've got some video clips, really quite high tech this time, and then we've got a Q&A at the end. And we really want to hear from you. Those of you who joined our previous sessions, I think will appreciate that some of the real value that we got from that was hearing from people who were working on the ground and who were delivering services, and some of the positive experiences they'd had, but also some of the challenges that they had. And if we can, the more we can make this a kind of shared collaborative forum and hear from the good and the bad of what people are experiencing, then the more rich and valuable we hope it will be for everybody. Please do put your comments and questions in the Q&A box as the presentation goes along. If there are particular procedural things, we may address the questions as we're going along, but in the main, we're going to address questions at the end. Similarly, if you've got experience, whether it's positive or negative, of any of the things that we're discussing in the course of the presentation, we'd really like to encourage you to add that to the Q&A box so that we might be able to discuss your experiences in the Q&A session at the end. As I said, in the spirit of improvement methodology, because we are an improvement team, we will keep refining and updating all our resources on the Futures platform. And so we encourage you to check back there regularly. And we really like to hear your feedback on what you find useful, what you find less useful, and any opportunities for improvement so we can get all of our products and our support as good as possible. So please keep engaging with us. Keep telling us your ideas for changes and improvements. And certainly if we've got anything wrong with the best of intentions, then please do let us know, because we really want to get everything right. Next slide, please. So today, you are here to talk about understanding backlogs, understanding a sustainable waiting list, and how to eliminate backlogs. Obviously, we haven't got a silver bullet for this, but quantifying and understanding the problem is part of the battle. So we're going to do a little bit of a recap on the basics of demand and capacity. We're going to talk about what a backlog is and how you can work that out, some different strategies that can be employed to reduce your backlog and what the implications are managerially, financially, and clinically, how you can monitor your sustainable position, a few tools which my colleague Nick's going to talk you through a bit later, and then we'll talk about how we can support your organisation with implementation. So, who are we? We are the Mental Health Improvement System Support Team. So, we're a small national expert quality improvement team, and we know that a number of you haven't joined our webinars before from previous feedback, so we're going to go through this gump every time, I'm afraid, for those of you that have joined us before. So our team is a national team. We work to improve services in mental health, learning disability and autism. We're a mixture of experts in healthcare management with senior experience of operational delivery, with senior clinicians who've also got experience of leading change in service improvement and service delivery in mental health organisations across the country. A number of our team members also have experience acting as an expert clinical resource, and across the team we've got experience of a wide range of specialisms, managerially, clinically, and in terms of service improvement approaches. Next slide, please. So this is our third webinar in the programme of support for mental health elective recovery. Just to be clear for those who might not be familiar with the notion of elective care and elective recovery, this is something which is widely used in acute care, and effectively elective care is non-urgent, non-emergency care. So something where you are planning, even if you're only planning a day ahead, something that you're planning in advance, so you're not accessing as an emergency. So we developed this programme to try to use our experience. So as a team, we've been working for 6 to 7 years, providing improvement and support across the whole range of mental health services, including early intervention psychosis, children and people's mental health, improving access to psychological therapies, dementia care, and pretty much every aspect of mental health implementation. We've done years of diagnostic reviews and assessments of services, and we've tried to crystallise our learning from these reviews together with methodologies from the elective care programs in physical health, including their post-COVID elective recovery program, to try to bring together our best efforts at what good practice in terms of delivering effective, efficient, high quality services for mental health elective care look like. Next slide, please. As I mentioned, this is just one of our modules on mental health elective recovery support. As you can see, we've got tried to cover the range of implementation across the mental health system, not just the mental health providers. So we looked at commissioning, access policies, today's webinar around waiting lists and backlogs, optimising capacity, which we did last time, pathway mapping, patient tracking, and finally improving flow. So the intention is that by the end of this selection of monthly modules, monthly webinars, we will have offered to mental health providers kind of complete package of everything that you should need to deliver the fundamentals of good elective care and mental health. Also, as I mentioned before, all of these resources are available already, even those for which we've not yet had the webinar, on our features site, address which is down there in the bottom left. So we always ask you for feedback at the end of our webinars. It's not just a kind of completely empty process. So we thought it would be important in the spirit of improvement, because as I mentioned earlier, as a team, we're keen to get better as much as we're keen to try to help you get better. So we wanted to let you know how we were using the feedback we got from you last time to try to improve our offering to you this time and in the future. So what we heard that people liked was having input from lots of different members of the team. So we made sure that we've taken a multidisciplinary approach to this webinar and will do for future webinars. We heard about what could be better in terms of making sure that we were, although we're trying to cover the fundamentals in an hour and a half, we acknowledge that all of these are pretty big topics. This is effectively the entirety of delivering mental health care services, and it would be naive to think that we're going to do that in a several 1.5-hour webinars. But we're going to try and make sure that we're focusing as explicitly as possible on the aspects of delivery which can be kind of most useful to you. So, for example, Nick's going to talk to you about how you can monitor your waiting list size, and Sarah will talk a bit later on some kind of practical tips about backlog reduction. And then thirdly, we heard that you wanted to hear more about targeted support from the team and also community of practice and peer learning opportunities. We spent a lot of time talking about what this might look like and what might work best for you. But then given the relative success of our Menti project last time, we're actually going to be, spoiler alert, we're actually going to be running a Menti on the best way, on the way that you would find most useful for that community of practice and peer learning offer to work. So we really have endeavoured to, as much as possible, listen to what you're saying, try to improve our offer based on your feedback, and we will continue to do so. And we would encourage you to adopt a similar approach in your own service improvement work. So without further ado, I'm going to hand over to my colleague Francis, who's going to talk you through our first exciting Menti opportunity.
Excellent. Thank you very much all. My name is Frances Iborke. I'm also an improvement advisor working in the team. I've worked in the team for a good 6 years now. And so there you are. I'm going to be your Menti compare for today. And how you access Menti is on the slide there. And I believe Michael has covered it. So if you go on to this link, enter the code, use the QR code in the normal manner, we'll be away. So first question coming up. Right, so how would you describe your current knowledge of managing backlogs? Fingers at the ready. I cannot see any votes coming in. Hopefully, aha, now we're coming in. Excellent. Right. Please all don't be shy. I can see the bars moving, so that's good. Excellent. So a fair few are coming in with having neither good or bad or limited knowledge, and that's good. That confirms you in the right place, and hopefully we might be able to improve that, increase that from this webinar and also from the experiences we'll share later. Great. Okay. Excellent. I think we can move on now. Over to you, Michael.
Thank you, Francis. As part of our continuous improvement approach, we're keen to evaluate the effectiveness of our webinar. So it'll be a useful baseline we've just taken in terms of what your level of familiarity is with the topic. Hopefully by the end of it, if we ask you, just hypothetically, if we were to ask you that same question again, we would hear that more people are familiar with it than were at the beginning. And I believe all the Menti results will be published when we circulate the slide pack at the end as well. So anyway, why is it important to understand your waiting list size and your backlog? So some of this will be familiar to people who have attended previous webinars, but I think it's worth reiterating that people with mental health conditions want and deserve timely access to treatment. Doesn't seem like a controversial statement, and yet we do not offer it to them. People with mental health conditions that are seen more quickly have better outcomes than people who wait a long time. And the people who are working in mental health services want to give people the best treatment in the most timely way. Furthermore, managing long waits, which is fundamentally what we're talking about today, is a resource-intensive, demoralising and non-value-adding activity. Nobody comes to work in the morning to be administratively managing people who they know are waiting longer than they would like to be waiting. And in services with very long waits, people can actually deteriorate before they're seen. That's something we see very regularly. So, services that really understand their demand capacity and waiting list position are less chaotic to work in, less stressful for the staff working in them, and less stressful and chaotic for the experience of patients who are accessing the services. The services themselves are able to see people more quickly, but without needing more money or staff to do so, because less time is being spent dedicating resources to managing a waiting list. Sorry about this. And are in a better position to make the case for additional investment. because as I tried to describe to you before, if you're taking a business case to your finance director, then being able to be very specific about the extent of the problem, exactly what it is that you need and why you need it, can make that case much more compelling. So understanding your backlog and your waiting list size is an essential and distinct component of effective demand and capacity planning. Next slide, please. So now we're going to watch a short video explaining a bit more about why demand and capacity is so important.
Colin has an outpatient appointment at the hospital today where Mariam works as a nurse. They both rely on the bus to get them there. To provide them with a good service, a whole team of people must work together to design efficient routes, keep buses working and make sure they have enough drivers. But sometimes buses are early and sometimes they are late. There is also variation in demand, meaning there might be more passengers at certain times or on certain routes. The healthcare system faces similar challenges. It is normal for demand for a service to change through the year. Sometimes this will mean the demand for a service exceeds capacity. So how do we plan better for variation in demand? If we compare recent demand data against our staffing resources for the same time period, we can model future demand and anticipate system pressures before they arise. This is demand and capacity planning, and it's more than just a data exercise. Demand and capacity models help us visualize a service's performance and the likelihood that it will meet patient demand, meaning Colin won't have to wait for treatment any longer than necessary. With good data, demand and capacity models help visualize how a service is performing and how likely it is to meet the demand from patients. Ensuring you have the data to input into the models can be time-consuming, but how do you know otherwise if you are planning to use your resources efficiently? Let's look at how demand and capacity planning can help you. For providers, when operational, clinical and informatics staff come together and commit to demand and capacity planning, the resulting improvements can benefit patients, staff and taxpayers. Input from consultants ensures patient-centred pathways, and booking staff, ward clerks and receptionists learn more about what changes they can implement in order to make things work more smoothly. Better evidence also helps trust finance directors decide how to allocate resources strategically. This minimises costly waiting list initiatives and agency work and ensures planning accommodates realistic demand for services. As with buses, making health services effective and efficient requires mapping out the system. For chief operating officers, demand and capacity is a large but invaluable undertaking. Once mapped, trusts can redesign service pathways based on demand and capacity models in order to maximise resources. And as the trust's capacity begins accounting for variation in patient demand, Colin's experience as a patient will improve. This is also true in the complex contexts of community and mental health services. In these cases, patients can require treatment and care for a longer period of time, so understanding how their needs change is crucial to providing good care. So demand and capacity planning in community and mental health services requires a more sophisticated model, but the underlying methodology still works to help create a clearer picture of the service. There are similar challenges in data collection and reliability, but investing the time will significantly benefit patients and staff. And without sufficient demand and capacity planning, experience shows patient lists will grow longer, which can affect clinical outcomes. Commissioners also have a responsibility for this. With a good understanding of demand and capacity, commissioners can take a strategic view of the local health system, then work with providers to make evidence-based plans and promote existing best practices. They can also ask the right questions at assurance meetings to ensure providers make the most of their demand and capacity planning. Then they can be more confident that providers will meet their targets and patients will receive the care they need. Demand and capacity work does require an initial investment of time and resources, but the improvements to care and efficiency have been shown to make a real difference to patients. Your first plan might not be perfect, but it will improve with every iteration. And going through the process together will generate dialogue and trust across different services and departments. Commissioners will better understand providers, administrators will better understand clinicians, and so on. Redesigned pathways will work more efficiently, and staff will feel empowered to act when problems arise. And your wait lists will become sustainable. Learn more about demand and capacity planning with the resource pack available as part of the Joint National Demand and Capacity Programme, and help Colin on his way.
Okay, good morning. I'm going to pick up the next few slides. My name is Nick Kitcham. I'm an improvement advisor with the team. I've been with the team for 6 years. Before joining, I worked in various service improvement and program management roles within the acute sector. So just building on that video clip and going into a bit more detail about backlogs. So the first essential fact is that all mental health services have multiple waiting lists. So you have people waiting for screening or for triage or for assessment or to start their treatment or to have follow-up appointments after they've entered treatment. So everyone has waiting lists. If a patient has an appointment booked for the next week or the next month, they're still waiting for that appointment to happen. And waiting lists aren't inherently bad. In fact, they are actually essential to running an efficient service. But they only become a problem when they exceed what we call the sustainable waiting list size, which is something I'll come back to. So the sustainable waiting list size is the number of people a service can hold and still see people within the required local or national standard. And the size of the sustainable waiting list depends on the service's average level of demand and the waiting time standard it aspires to deliver. So it's not affected at all by the capacity in the service. And then backlog is a very specific term we use to describe the number of patients waiting above the sustainable waiting list size. And calculating the backlog is something which is quite straightforward to do. It's something all services should know and should be monitoring in order to stop situations getting out of hand and people waiting too long. So let's just go to another quick Menti poll now.
Thanks, Nick. I gather that some of you had a bit of an issue in the first Menti poll, so I'll give an extra minute and hopefully those issues have resolved. So thinking about how you plan your capacity, the question here is, how do you plan your capacity requirements for the next year? Is it on the basis of a referral rate last year, or the referral rate last year plus estimated growth or reduction? Is it based on the activity last year or the activity last year plus estimated growth? Right, it's coming in now. Or is it based on budgeted capacity or commissioned activity levels or access rates? So it seems most are coming in based on the referral rate last year plus estimated growth. The other answer, sort of like at roughly equal levels, as based on the activity last year plus estimated growth. So those are the two most frequent answers, and there are some sort of others in between, a mixture, really. Okay, so I'm sure you're dying for the answer, and Nick is going to give us the answer in the next slide.
Thanks, Francis. So yeah, a range of different methodologies people are using, and there are right and wrong answers, although technically there can be different approaches you can use. But just to go into some of the details and the key elements you need to understand when you're looking at your overall demand and capacity and backlog management, and it's these three key concepts which we're just going to briefly touch on. There are further resources in the National Demand and Capacity Teams training program, and we'll be referencing that later. So lots more detail you can go into, but just to cover some basic concepts. So demand is the work you need to do, the patients you need to see, it's the referrals coming in through the door, it's whenever treatment plans are made or revised, that's a new source of demand. And the sort of data you need to be able to look at and understand to really fully get a grip on what the demand situation is are things like the level of variation, by hour or day or week, depending on the urgency with which you need to see people. The dropout rate for treatment, the intervention or treatment types, the localities, if you've got a team covering multiple geographies, and the expected dose according to the pathway. So they're all the components that make up the demand on a service. Your capacity is the work that you're able to do based on the staff or resources you have, which typically will be counting for elective care in terms of the number of treatment slots by intervention. And here you need to factor in all the things which take capacity out of the system, for example, planned leave, sickness absence, training, supervision, team meetings, travel, and so on. And finally, the last component is activity levels, which is something that you shouldn't be using to plan your future capacity requirements. So activity is the work you actually do, the number of appointments you deliver, the number of people who are seen. And to look at this, you need to count the number of actual attended contacts by intervention, which will be typically different and less than the number you plan to or could potentially be delivering. And that's obviously because you have unplanned events which are impacting on your capacities, for example, further staff absences or vacancy rates. So activity levels and capacity levels shouldn't be used to calculate your future capacity requirements. You should be looking really purely at the demand, because once you start looking at capacity and activity, you're actually filtering down based on the constraints and restrictions within your service. So the correct answer is use your demand to look at your capacity you require in the next year, and then adjust that based on your budget and your resources available. Next slide, please. So this is just a visualization which is bringing together all those key concepts really around demand and capacity planning. It's showing a sort of funnel. In terms of the left-hand side, you've got the demand coming in, which is all the requests for a service from all sources. And then you may have people waiting, joining a waiting list. And if you've got people waiting above the sustainable waiting list size, you've then got a backlog going into the filter. Then at some point in the system, you've got a bottleneck, which is again a specific definition we use to describe the most constrained capacity within a system. This could be staff in a particular discipline or team, it could be clinic rooms, it could be a number of things, and it may change from time to time. But within any system or process, there will be at any one time a specific constraint, which is the most constrained capacity within that process, which is limiting the number of people you can see and treat. So coming out through that funnel is the capacity, which is the maximum number of people you can see or treat, and then somewhat less than that is the activity. So that's the people that you are actually seeing. So those are the key concepts within demand and capacity planning, and we're going to come back to look in a bit more detail just about the backlog and the calculation of that. So let's just go on to a quick Menti poll about the bottlenecks.
Thanks, Nick. So the question is, do you know what the bottleneck is in your service? Right, we're off the blocks. The range of answers, as we can expect, but mostly it's around staff shortages, which is the most popular answer. Staff shortages due to vacancies and sickness and absence. And that's followed by staff shortages due to underfunding. And these are very common themes that resonate in the mental health sector at present. Okay, I think that's quite a strong response there. So what's going to follow after this is a short video on waiting list size. And after that, Nick will lead us through the next section.
People tend to think that having people on a waiting list is a bad thing. But in this film, we're going to show you how having a waiting list that is the right size can help offer people choice and flexibility in when they're seen, as well as achieving a maximum waiting time. To help keep things simple, imagine this is a new service, so there's no existing waiting list or backlog. Here is the puzzle. How big does the waiting list need to be in order to meet our own standards by seeing everyone who's referred to us as a routine patient within 5 weeks? And because these are not urgent referrals and life is complicated, we also want to offer appointments with at least 2 weeks' notice. Let's assume an average of 24 patients are being referred every week. In this first starting group are Mary, Mike, and Mariana. We offer each of them a choice of week 3, 4, or 5 in which to be seen. Mary can't be seen in week 3 as she has an important work deadline, which she fears might even run into week 4, so she chooses to be seen in week 5. Mike's mum is visiting from Australia in week 3, but she's going home on the Friday, so he chooses week 4. Mariana, on the other hand, has more flexibility with her time and is free to be seen as soon as possible, so chooses week 3. Like Mary, Mike, and Mariana, each patient in this first block will have their own reasons for choosing when to be seen. In the first week, another 24 patients are added, and these too will make their own appointment choices, giving us 48 people in the waiting list, with no one having yet been seen. Week 2 arrives, and another 24 people are added, taking the waiting list to 72, still with no one having been seen. In week 3, Mariana and the others from the first block of referrals attend their appointments. Those who've chosen week 4, like Mike with his mum visiting, and those from week 5, like Mary with her work deadline, are yet to attend their appointments. So 8 people have now been seen and come off the waiting list. But don't forget, another 24 people have been added, so the waiting list number is now 88. I know, this keeps going up, but it will stabilise soon, I promise. Now comes week 4. Mike's mum has now gone home, so he and the others like him attend their appointments, along with those who are able to be seen as soon as possible who arrived in the middle of week 1. But the Marys from our initial group and the Mikes from week 1 carry on waiting. Meanwhile, another 24 patients come in and again make a choice about when they want to be seen. This week we've seen 16 patients, but we also have another 24 patients being referred, so the total number on the waiting list is now 96. Let's look at week 5, where everything becomes clear. The Marys from the initial group are now able to fit their appointment in around work. The Mikes from the second block have finished with their personal commitments, and the Marianas from block 3 are also being seen. We're now seeing 24 patients, which is the same number that are being referred into the service. The waiting list number holds still at 96, and it won't go up anymore. Let's see what happens in week 6, when we add and see another 24 people, and in week 7, 8, and 9. As long as the number of people being referred and the number of people having their appointment stays the same, we have an ideal waiting list size of 96. We have arrived at a stable system, and we know that with a waiting list of 96 people, we can offer everyone at least 2 weeks' notice, a wide variety of choice, and see them all inside of our own 5-week target.
Okay, so I think probably for quite a few of you attending that will have made a lot of sense and you'll understand the concepts but I know for quite a lot of you probably it will just be completely baffling. So this is the only maths bit in the session really, and you don't need to know this because we've got a tool which performs the calculation for you. But for those of you who do like to see the numbers and see how they fit together, let's just step through that calculation that was given in the example. So to calculate the sustainable waiting list size, you only need 3 pieces of data. That's the demand, so the average number of patients per week in this example, and the booking window. So how soon you can start booking people after their referral, and what's the latest that you want to be able to book people within. So your target maximum wait rather than your actual wait, which may obviously be somewhat longer. So just those 3 pieces of data, and as we've said before, the capacity doesn't come into that calculation, and you can substitute hours, days or months for the weeks in the formula if you do that throughout the formula. So for urgent services, crisis services, you may be looking at hours rather than weeks, but the formula still applies and you get a sustainable waiting list size from this example of 96. So this, as I say, the capacity isn't a part of that calculation, but in order to run an efficient service, an effective service, you need to have both your sustainable waiting list size calculated, but also your capacity in the background enough to see your average demand. And in fact, you need to set your average capacity in excess of the average demand, and we'll come back to that on the next slide. But if your waiting list is a lot smaller than the sustainable waiting list size, so in this example, if you just had 30 people waiting, then you're likely to be losing slots, losing capacity, because you can't actually efficiently schedule the slots that you want to book. So it's a formula which gives you an exact number, but obviously in the real world things aren't that precise. But if you've got a calculation which is saying your sustainable waiting list size should be 96, then you should be aiming to be somewhere between probably 85 and 105 or so, in that sort of ballpark, in order to be able to deliver the timely care that you require. And of course, because demand is a key part of the calculation, as and when the demand changes, your sustainable waiting list size changes. So you do need to monitor that and recalculate as appropriate. Okay, next slide, please. So whereas for the calculation of the sustainable waiting list size, you only need to look at your average demand, which is an easy calculation to make based on your data. A key concept of demand and capacity planning is the idea of variation in demand and setting your capacity at somewhere above the average demand. And we talk about this in terms of percentiles. And this example, this grid here, shows a range of services across mental health and acute care. So in the bottom left quadrant, we've got orthopedics there, where your response time is typically relatively slow compared to some other services. So you've got months in which to schedule appointments, and you've got a low variation in demand because you've got a very high volume of patients coming through. So from week to week or day to day, the average percentage change in the level of demand is going to be less than in services with smaller numbers coming through. So at the other end, in the top right-hand side, we've got hyperacute stroke unit and mental health crisis services, where you've got a relatively smaller volume of patients. So the variation in demand is higher, and you've got a much shorter response time. Obviously, you want to see people within a few hours. And where the service fits on this grid will determine at what percentile you need to be pitching your average capacity. So typically for mental health community services, for example, the Children and Young People's Mental Health 4-week wait standard or IAP services, we think you need to be looking at around about the 65th percentile. That's a good starting point for planning your capacity going forwards. Okay, let's go to another Menti.
Right, so by now you're probably getting really good at this. So just reflecting on your service and what you've heard so far, what do you think are the main causes of backlogs in your service? We've provided a range of options there, and there may be other reasons. Right, and we're off the blocks. What's coming out strongly so far is insufficient capacity again, based on vacancies and sickness. And following this is a growth in demand and also insufficient capacity underfunding. That's kind of similar to the previous question. There are also responses which indicate perhaps inefficient booking and scheduling processes, or an unsustainable model or pathway being in place. But there's also opportunities there in terms of DNAs and cancelled appointments, and perhaps being managed differently. Okay, so that's the scores on the doors. I'll hand back over to Nick.
Thanks, Francis. So yeah, quite striking there that the main issue coming up is staff vacancies and sickness being an issue contributing to the backlogs. So this is our tool, which you can download from our Future NHS site, which performs the calculations of your sustainable waiting list size. It's a simple Excel document, and again, very light on the data requirements. It's only those 3 elements that we've looked at in the formula. So we've split this between an assessment pathway and a treatment pathway, but in actual fact, you can use it for any 2 different pathways within a service. You enter those key pieces of data, so the average demand and the minimum and maximum target weights. So again, not your actual waiting time now, but what you aspire to deliver, and the number of people you've got waiting now. So in this example at the top, the assessment pathway has 432 people waiting for an assessment, and the calculation says that your maximum sustainable waiting list size is 400. So you've got a small backlog there over 32 people. But the issue in this example is really more around the treatment pathway, where the backlog is 164. So your current waiting list is considerably higher, and that's likely to be borne out in the waits for treatment being much higher than you'd like to be delivering based on your standards. And next slide, please. So the other element of the tool is this simple chart, which is showing you trajectories for your baseline position. So your sustainable waiting list size in the green, your capacity in terms of slots in grey, and then the purple line is showing what's going to happen to your waiting list for the baseline situation if you do nothing. And then it allows you to model a plan scenario in which, in this example, we've got some increases in capacity over the short to medium term. And this gives you a trajectory for the next 12 months as to how that's going to impact on your waiting list size. So obviously you want to come up with some sort of plan which is tackling your backlog and getting you much closer to, if not below, your sustainable waiting list size. Next slide, please. So if you do have a backlog and you've used the formula or the tool to calculate that you do have a backlog within any of your services, what can you do about it? And essentially there are one of 4 things, 4 different strategies or approaches. So firstly, in the top left, you should be looking for inefficiencies in your service. Is there wastage? Are you losing slots due to cancellations or DNAs or inappropriate referrals? Do you have issues with your basic pathway in terms of barriers and unnecessary steps that are taking out capacity? And then things like group offers, if it's clinically appropriate, can you make more use of those to increase the number of people you can see and treat with your existing capacity? Once you've exhausted those options and you think that there's really very little more you can do to increase efficiency, you may need to move to the top right quadrant, which is about adding some short-term capacity. So this could be in the form of overtime or temporary staff or recruitment, but obviously pretty challenging given what we've seen in the last poll and some of the staffing issues we have. So this strategy will obviously come with some form of cost to the service or to the system, but it may be a desirable overall strategy in terms of getting to a more reasonable position. and then a more sustainable position where people are seen and treated more effectively and efficiently. In the third quadrant, we've got an option to move demand. So in some cases, this may be outsourcing, or it may be looking across your ICS as to other providers who can pick up some of the activity that needs to be done. Can you move some services around on a temporary basis? Can you refer onwards perhaps to a digital offer, which has been used, we know, in many cases over the last couple of years as a relatively short-term solution to tackle some of the overwhelming demand. And then the final category, which is really the last resort, is around doing less, although there is one very potentially effective strategy, which Sarah's going to talk a bit more about on interim pathways. And then as a last case scenario, potentially suppressing referrals or tightening acceptance criteria, which unless you think there's a very valid and clinically sound reason for doing so, it's obviously likely to be quite a problematic idea. So that's the four main categories. And now Sarah's going to talk a bit more about the waiting list initiatives and the interim pathways.
Thank you, Nick. Hello, everybody. My name's Sarah Brennan. I'm a mental health improvement advisor with the team, and I've been with the team nearly 6 years. Prior to that, I worked for around 20 years in mental health services. I'm a registered mental health nurse by my professional background, and I've held a number of clinical, operational and governance roles within that time. So the next few slides, we're just going to focus really on talking through a few approaches and tips around clearing backlogs. And that takes us back to that slide earlier on when Michael was saying about the feedback that we'd received from other webinars, where actually having useful tips within the webinar is something that people wanted. So hopefully we are helping you with that. So in terms of the approaches we're outlining here, they're not mutually exclusive, and a combination of methods may actually be needed. I think it's very important to think about where there are long waits. So if there are very long waits, there are a few things that we need to be mindful of. And the first is the needs of those waiting may be different now to when they were first referred or assessed. So there we have to think about, do we need to think about sort of capacity for reassessment for those very long waiters? Additional measures should be put in place urgently, really, to ensure that the safety of those long waiters is met. So, for example, what are the processes and protocols of sort of keeping in touch with those very long waiters so we can understand what their needs are, or indeed if there's any sort of escalation in sort of risk or harm. Both of these do result in additional activity or reworking, and both will have a capacity cost. So that is very important to bear in mind when thinking about your backlog clearance plans and approaches. Clinical needs should always drive prioritisation, but waiting list protocols such as access policies can be used to ensure or should be used to ensure that available slots are used in such a way that prevents everyone waiting until they reach that very highest risk or priority level before being seen. Next slide, please. So just coming on to some of those backlog reduction tips then, and thinking about not being afraid about going back to basics with this. So model for different scenarios for backlog reduction. Have in mind when you're doing that a number of sort of questions that you might want to ask yourselves and within your team conversations, such as, does the service understand the current backlog waiting list problems? Is the service able to sort of quantify the number of people waiting, the length of the waits, and for which treatments or steps that they might be waiting for? Has there actually been a validation exercise around those sort of backlog or those waits beyond the sustainable waiting lists? So, for example, is what you're saying actually accurate? When should the backlog be cleared and by when? So really being very clear about such your timescales. Asking yourselves what actually is feasible, and then thinking about, and this is what Nick was talking about, the potential for interim pathways. Is there a need to sort of design new pathways, but in the short term, is there a need to introduce an interim pathway alongside your business as usual pathways? If that is something that you're wanting to consider, there are a number of things you probably need to be thinking about, really. One is about the whether that is ethical. So, for example, if you are putting in interim pathways, you need to ensure that the clinical need is still driving prioritisation, and any intervention that is offered needs to be appropriate to meeting the needs of the people that are coming into your pathway. I think finally on the questions, really, it's about asking yourself, is it better to set an ambitious target and fall short of that and then reset than setting a very safe target that is probably quite a long way in the distance? I think other tips are around creating weekly and not monthly trajectories to eliminate your backlogs. It's thinking about disaggregating those weekly targets to daily targets and thinking about those not just on a team level, but an individual practitioner level. Are you able to balance your referrals, assessments and treatment starts and discharges? And thinking about your demand or capacity, if that changes, replan. And I think the thread that might pull all that together is any sort of strategy or approach that you might be taking. Think about your communication strategy. Are all key stakeholders that need to be aware of the plans or any changes actually involved and informed of that? Next slide, please. So there are three sort of key strategies that we would sort of be saying would support you in your sort of approaches to backlog clearance. The first being the actual backlog clearance activity, and Nick spoke about this in a little bit more detail, but these are sort of your one-off short-term initiatives that need to be completed in weeks and months, not over a longer period of time. And examples of that is where you might want to add temporary capacity, redeploy capacity, reduce activity, and that might be through outsourcing or introducing those interim pathways. And it may well be about reducing demand, albeit we probably would not be recommending that in the first instance. Alongside that is about thinking about your capacity planning. So how are you linking your capacity planning to your business planning cycle? And that's a much more medium-term approach and an annual approach. So, for example, making sure that you've got robust demand and capacity modelling built into your business planning cycle, thinking very much about sort of the needs of the people that are accessing service. So is there a need to think about pathway redesign? And then the wider issues such as your workforce strategy, so workforce planning, recruitment, retention, and those sort of career development opportunities and how that impacts on then that strategy. And finally is thinking much more around those day-to-day sort of activities that improve productivity or efficiency. So daily continuous improvement activities, and examples of that could be introducing therapist dashboards, focusing and thinking about what your discussions around backlogging your supervision and clinical leadership meetings, thinking about are your booking systems as effective as they can be, what are your approaches to reducing do not attends, and how are you actually sort of engaging in daily discussions with clinicians, for example, through huddles or cells. So that's it from me. I'm just going to hand back over to Nick now, just so he can sort of wrap up with some sort of final key messages. Okay, thank you. Thanks, Nick.
Thanks, Sarah. So yeah, we'll shortly be moving on to the Q&A and discussion. So please, would be very keen to hear from any of you who've taken part in any backlog initiatives, or you've tried to tackle them and had some success, or you've tried and not succeeded. Really keen to get your experiences and get a bit of discussion going on about that. So please post in the team's Q&A any experiences you have, and we could potentially come to some of you during the Q&A session. So next slide, please. Just to sum up then, really managing long waits inevitably uses capacity that would be much better used actually supporting the delivery of care, and long waits will lead to increased caseload acuity and require more capacity or staff time to see the patients who are coming through. And this is likely to increase the pressure on staff and potentially result in low morale or burnout as a key risk, and will potentially also lead to poorer outcomes for patients. But if you do clear a backlog, but you don't have enough capacity to meet the ongoing demand based on your model, then the backlog will return, So you need to have both sides of the coin. And if you do introduce an initiative to clear a backlog, then you should also be implementing systems which monitor waiting list sizes so that you can preemptively flag when things are going in the wrong direction and you reach certain thresholds or tolerances against which you need to reconsider your approach. And finally, we don't underestimate the challenge that a lot of community mental health services are facing, and we know that actually getting to a balanced waiting list position may require quite significant medium to long-term work involving redesign of pathways, looking at the overall workforce and finances. But even if this is the case, then effective backlog management processes can still be used very fruitfully in the short term, just to understand what the position is and to get a grip on the situation. And ultimately, in some cases, actually just stopping the deterioration in a waiting list position, or slow it, or stabilizing a waiting list and not increasing it could be an effective short-term result as you look to seek a longer-term solution. Okay, I'll now pass on to Simon, who's just going to talk you through some of the other support available before we move on to the Q&A.
Thank you, Nick. So many of you will have heard this before. I'll try and keep it as punchy as can be so that we can get on to the discussion thereafter. My name is Simon Bristow. I'm a system improvement advisor in the team. I'm a mental health nurse by trade and have spent more years than I care to consider working across a number of clinical, operational and governance-oriented roles prior to joining this team. Some of you will have worked with us before, and we are very excited to have the opportunity to work in a different way than we were commissioned to do so before. So all of these resources that we are talking about today, alongside all the resources that are associated with all of the other modules, are made available to all systems as of now for free via our future NHS platform, which is linked to in the Q&A section here. And in recognition of there's quite a lot of stuff in there, and some of it will be more familiar to some parties on the call than others. So we are offering implementation support to everybody. So we've got, for the first time, a universal national implementation support offer. So we are doing these webinars for each of the modules. We are also offering a free bespoke coaching consultation and support to all systems who want to use the resources, as well as some additional bespoke sort of boots on the ground deployment support to systems that have been identified as being particularly challenged via the various national mechanisms that do that. We're working with our regional colleagues to build capability within the existing regional improvement support structures to enable people to provide support to ICBs and trusts directly from that route as well. And we're working with our colleagues in the model hospital around working to iteratively develop their metrics that look at quality and unwarranted variation issues. So hopefully you will see some fruits of those coming your way soon. Also, can I have the next slide, please, Asker? If you did want to work with us around this, then, as I said, it's free. There's no prioritization criteria other than that you would want to do the work and are able to apply the resources and political will in order to do so. And the sort of things that we'd be expecting to do with people would be around coaching implementation leads, coming to the governance meetings, looking at plans, and working through some of the nuts and bolts of some of the detail of some of the things that you might find particularly tricky. And if this sounds familiar and that sort of approach sounds useful, we would recommend that you have a look at the resources on the Futures platform, have a chat with everybody who you think needs to be involved, think about what might be the barriers and enablers, and what resources you might need in order to allow this work to be done properly, because a lot of the benefits in the modules that we're talking about are best realised through getting it right in the first instance rather than trying to fix things later. And contact us. Have a chat with us about what it is that you want to do, where it is that you might want to start, what it is that you think you might need in order to get there. Can I have the next slide, please? So the sort of things that we would be asking of you if you do want to work with us around deploying some of these approaches. I mean, obviously, there's no obligation to do that. You're more than happy, more than welcome to take them and run with them and do them of yourself. But if you wanted to work with us around them, we would ask that you identify named leadership who's going to be accountable for delivering it. We'd ask for you to identify project resource and leadership capacity, a forum to oversee delivery, reporting routes, developing and delivering a plan, committing to changing your policies and procedures, and working with us around assessing the sustainability of the changes that are being made. Can I have the next slide, please? So these are the contact details. Each region in the country has their own link, and when these slides are distributed to people who have joined the call later, these will be hyperlinks with which you can click and contact us, or you can get hold of us via our team email box that's listed here, or the features platform. Next slide, please. We are also running the rest of the webinars in the series across the rest of this financial year, and you can find the webinar recording for this session and the previous sessions on the Futures platform, and the links again will be active working hyperlinks when you receive this slide deck. Next slide, please. So we've been working closely with our colleagues in the demand and capacity team within NHS England, so I just wanted to give them a bit of a plug, because I don't think we've got anyone from the call from their team today. They are very skilled, knowledge and experienced colleagues who you know, the seasoned national experts in demand and capacity planning. They have a suite of resources both on their main NHS website as well as their future NHS collaboration platform. They do training. There's an e-learning module that they have, and they have over the course of the last 6 or so years been developing a cohort of 300 odd locally embedded trainers who can provide bespoke support into organisations who are doing demand and capacity modelling. And I've got some practical experience of working with them and one of their graduates from their programme in supporting an ICB to undertake some demand and capacity modelling in children and young people's mental health services of late, and it has been really high quality, and I think is going to be very useful to the respective organisations' boards that are involved. Can I have the next slide, please? So they do a bunch of different models. On the main NHS platform, you can find their officially published models, which are the core model, high complexity model, and aggregation model. They were originally designed for acute care, essentially, and which is where the demand and capacity program started. They have moved through into developmental models that are probably more applicable to most mental health settings. So there's an urgent and emergency response model, which would be most usefully used for things like crisis pathways. And there's a caseload model that was co-produced with colleagues working in mental health trusts, including CNTW, I believe, and they're looking at CMHT type care, basically. So that's particularly helpful for many people on the call, I'm sure. They do lots of different, generating lots of different case studies. They're publishing them on the Futures platform. As I said, they're real fonts of all knowledge, and I would highly recommend using them if you want to do any demand and capacity modelling. And we co-work with them, so if you want to do some work that looks at kind of backlog clearance or any of the other modules, as well as the broader demand and capacity piece, then do let us know. Can I have the next slide, please? There's also another model called the CREST model that the mental health policy team commissioned, that is a web-based platform that was initially designed for CYP, but is broader applicability to other settings as well. The benefits of this one is that it is a web-based platform. It's easily accessible for anyone who's got a future NHS, an NHS.net address, and it produces these nice diagrammatic representations of what's going on, as well as is able to look at seasonality and demand, which is obviously particularly useful for some settings such as children and people services. Can I have the next slide, please? At this point, I'll hand over to our colleague Tom Ayres from the National Collaborating Centre for Mental Health, who is we're going to be working with around their demand and capacity and flow QI collaborative that I will let Tom talk to you about. Thank you.
Thanks, Simon, and hello everyone. So just to introduce myself, as to follow on Simon's introduction, my name is Tom Ayres. I'm the Director of the National Collaborating Centre for Mental Health. We are a team based at the Royal College of Psychiatrists, and we do a range of work which I'll talk about in a moment. I've been in this role for about 6 years. Prior to that, worked in mental health services for about 12-ish years, most recently as a Director of Community Mental Health Services. In this, the NCCMH, we do a range of work that's broadly split into 2 streams. One is to develop evidence-based policy for the NHS in England and other countries, and the second is to run QI, or quality improvement collaboratives and programs to try and implement best quality care. And we've run over the last few years programs on reducing the use of restricted practice on inpatient wards, helping people to enjoy work and reduce burnout amongst staff, both of those with really excellent results. Improving sexual safety on mental health wards, suicide prevention, advanced mental health supports, so a range of areas. And we are a team of experienced and trained quality improvement coaches, and all of our QI work is overseen by our National Improvement Lead, who's Dr. Anand Shah, who's also the Chief Quality Officer at East London NHS. When we were this summer thinking about what our next improvement collaborative would be, we asked some leaders in the system about what they felt their priorities were, and managing demand and capacity and flow was overwhelmingly the choice of those leaders is the issue in mental health services at the moment, which I guess people on this call broadly agree with. That's why we're here. And so we are setting up a collaborative which we're currently recruiting for, and we're recruiting teams to join throughout November. Registration deadline is the end of November, with the collaborative due to start in January to run for 18 months. So we were doing that work independently, and then I was really delighted that Simon got in touch with us to say actually there's a real serendipitous connection with this programme that the team are running, talking about today, and over all the things that we talked about and on the Future platform. And we really, I think both of us saw our 2 programmes as really complementary to each other. And hence I've been invited to just speak for a couple of minutes today about our programme, which we're really grateful for. So we think that our work can really complement all the brilliant resources that have been put together by the team today. And what we think we offer on top of that, I suppose, is we're not offering new tools in management and capacity for existing excellent tools that we're taking through something today, but really offer support with the human elements and the complexities of actually putting it into practice. So this work's really complex, and particularly in mental health, and one of the videos referred to that earlier. One of the pieces of work we did a few years ago was developing the community mental health framework, which is underpinning the community mental health transformation programme, which I guess people are aware of. And the ask within that is talking a lot about reducing barriers between primary and secondary care, health and social care, statutory voluntary sector. It makes this all really, really complex, even more so perhaps it was before in mental health. And I can, when I manage mental health services, I would say the normal approach to managing increased demand or problems with backlogs was that one on the bottom right quadrant, which was to tighten the criteria for services, and lots of complaints from patients, lots of complaints from referrers, and actually from staff as well. So when we spoke to staff about it, they said, we hate doing this, but we can't see any way of managing the backlog that we've got. And actually we work with them using quality improvement approach to think about actually doing something different. They said, we want to provide something for everyone, but we need to do it in a different way. Some real successes with that. So it's complex, but we think that best quality improvement approaches work because they give teams a safe process and support and the ability to solve their own kind of complex problems, and this is the most complex problems that teams face. So our approach is very people focused in the way that we do our work. The support provided is from an experienced quality improvement coach who worked with a team for 18 months. There'll be a mixture of going in person to teams, providing virtual support. We also will have a series of collaborative events, learning events throughout the 18 months, at least bi-monthly, but with other things in between as well. And that'll be a mixture of in-person and virtual sessions as well. And we also support around the measurement and helping people to understand where the changes they've made have made a difference to what's happening as intended. There is a cost to this, so we don't have core funding. We are funded to do work in different ways. The funding model for this is a subscription-based program, which is roughly half of our programs are subscription-based in the past. We don't make profit, we're a charity, but we do have to cover our costs, and the cost for this program is £7,000 per team for the whole 18 months. We apply a 10% discount in an organisation signs up more than one team, so it's £6,300. That it's 18 months. It actually crosses over the period January 23 to July 24. Obviously crosses 3 financial years. We have flexibility to take payment in any combination of 1, 2, or 3 financial years is most convenient for an organisation. And like I say, we try and keep the costs as low as possible, but we do have to cover our costs in doing this. So we, like I said, we want to work with this programme. We think there's an added benefit from joining this. Obviously, it's a small cost as well, but we're really interested in talking to anyone who's interested. You can have a look on our website. The address is on the bottom there, and contact us. There's contact details all on there. Or my email address, if you want to contact me directly, is tom.ayres@rcpsych.ac.uk. I'm conscious I need to leave time for Q&A for the whole session, so I'll finish there and hand back to Sam.
Thank you, Tom.